Good morning, everyone. Can I bring the Pension and Health Benefits Committee to order? First order of business is roll call.
Priya Mather.
I'm here.
Steve Juarez for John Chung.
Here.
Rob Fechner.
Morning.
Richard Gillihan.
Here.
Henry Jones.
Here.
David Miller.
Here.
Bill Slayton.
Here.
Teresa Taylor.
Morning.
Alan LaFosse for Betty Yee.
Here.
And please note also for the record that we have Ms. Hollinger, Ms. Brown, and Mr. Rubalcava also with us in attendance this morning. Before I move on to the next agenda item, which is the election of the Pension and Health Benefits Committee Chair and Vice Chair, I just want to take a brief moment of personal privilege to say that I'm stepping down as chair of this committee after, I think, more than a decade of serving this committee. And it has been such an honor to work with all of you, to work with this committee, to try to drive better health outcomes and reduce the cost of healthcare for our members. And we've had such an amazing team working at the helm for both on the health side and the benefit side. And I just can't express to all of you what a pleasure and a joy it has been to serve as chair of this committee. Excuse me, choking up a little. Okay, so with that, I will now entertain nominations for chair of the Pension and Health Benefits Committee. Ms. Taylor.
Yes, thank you, Madam Chair. I'd like to nominate Rob Fechner for chair of the Pension Health Benefits Committee.
The name of Rob Fechner has been entered as for chair of Pension and Health Benefits Committee. Any other nominations? Are there any other nominations? Are there any other nominations? Hearing none, I'll entertain a motion to elect Rob Fechner as chair of the committee by acclamation. Moved by Ms. Taylor, seconded by Mr. Gillihan. All in favor, please say aye.
Aye.
All opposed? Motion passes. Congratulations, Mr. Fechner.
Thank you, Madam Chair. It brings us to the next agenda item is the Vice Chair of the Pension Health Committee. I now open nominations for Vice Chair of Pension and Health. Ms. Mather.
Thank you. Well, it is my pleasure to nominate Ms. Taylor for Vice Chair of Pension and Health Benefits Committee.
Thank you. Ms. Taylor's been nominated. Any further nominations for the office of Vice Chair? Any further nominations for the office of Vice Chair? Third and final time, any nominations for Vice Chair? Seeing none, nominations for Vice Chair are now closed. I will propose that we elect...
By acclamation?
There we go. We have a motion and a second.
Second.
It's been moved and seconded that we elect Ms. Taylor by acclamation to the position of Vice Chair. All in favor say aye.
Aye.
Opposed, no. Motion carries. Congratulations. So now we're going to take a quick 5-minute break to allow the staff to move everything around up here. So we'll be right back with you. everybody. Nice to see everyone this morning. The next order of business, item 3, will be executive reports. Ms. Bailey-Cremens and Ms. Lum, please.
Good morning, Mr. Chair, members of the committee, Donna Lum, CalPERS team leader. Before I get started with my executive report, I'd like to extend congratulations to Mr. Fechner for your election to the chair of this committee, as well as Ms. Taylor as the vice chair. In addition, I'd like to welcome Mr. Miller to the committee and also our new board members and representatives for observing the committee as well. I have a couple of updates that I'd like to share with you. And first, kicking off our CalPERS benefit education events, we successfully kicked off the 2018 year with 2 events, one which was held in San Luis Obispo on January 26th and 27th, and the other in Sacramento on February 2nd and 3rd. As you are aware, the CalPERS benefit education events, also known as the CBs, are one of our most important member outreach tools. During these events, we're able to communicate face-to-face with our members, answer their questions directly across the state, and we also offer classes that are geared towards a member's life cycle from mid-career to those that are nearing retirement. We have a lot of exhibitors that are there to assist with questions and to provide information to help our members get ready for retirement. In San Luis Obispo, we had over 950 attendees for the 2-day event, which far exceeds the highest attendance that we've had in that area, which was previously 520. So we almost doubled the attendance there, which again demonstrates that when we do go to our outer cities and our remote areas, that we do get quite a bit of attendance. And this is considered to be one of our remote CBs for the sheer fact that the nearest regional office is 2 hours away in Fresno. So again, we're very pleased to be able to serve that membership. We followed up with San Luis Obispo with our largest CB each year, which is here in Sacramento. And through extensive planning and preparation, we were able to assist over 3,600 attendees during the 2-day period. The team was very delighted to be able to share the CB experience and to visit with a couple of our board members that attended. And we'd wish to thank Ms. Brown, Mr. Miller, and Mr. Fechner for attending the CB. Hopefully for Ms. Brown and Mr. Miller, this was your first CB and that it was a positive experience. I'm always continuously impressed with the team's commitment to customer service and to our members. We did have to overcome a few minor challenges as we were preparing for the large events, but the team and their dedication was able to overcome those challenges and ensure that our members were going to have an excellent experience. We do have 4 events remaining for 2018, with the next event scheduled to be in Visalia on March 2nd and March 3rd. Next, I want to share with you a couple of the things that we've been doing in the areas of customer service that really are in alignment with our strategic plan of reducing complexity, reducing paper, streamlining our processes, enhancing our member and employer online services, as well as enhancing our member and employer services. So we recently revised what we call our My CalPERS employer guides to eliminate the non-added, value-added information, as well as to reduce jargon and to make the document much more readable. As an outcome of the work effort, we were successfully able to reduce the page count by 47%, which then will result in approximately a $20,000 savings in printing each year. So an ongoing savings that we expect to achieve. In addition to that, we've also been reviewing our content for our classes for our employers, and we were recently able to streamline the content and make it much more accessible to our business partners and our employers. And so, for example, our retirement enrollment for public agencies and schools course is now 2 hours versus 3 hours. So again, an example of how we are looking across the branch and across customer service to streamline our processes. We also added an enhancement in January to our member self-service, so this is the online service that we provide to our members. And in December, we implemented the ability for our members with a community property claim on their retirement account to be able to apply for retirement online. Previously, this option was not available. So as you'll hear in the next part of my report, we are continuing to see quite an uptick in the trend of retirement applications being submitted online, and providing this additional option for those with community property will continue to promote our member self-service. And then lastly, as we rounded out last year, I just wanted to share with you some statistics as related to our service retirement. We processed over 37,000 service retirement applications in 2017, which was an increase of 3,060 retirement applications over the 2016 calendar year or fiscal year. The volume of self-service applications has steadily increased in 2017, peaking at 38% of the total applications that we received in September and December were applications that were submitted online. In addition to that, on the January monthly roll, we successfully processed over 6,500 members retirees onto the roll. And of that total, 4,044 were for retirement dates of December 30th and December 31st. So you can see the high volume of the retirements in the short duration of the time frame that we have to get them onto the roll to ensure that they receive their benefit payment without disruption is an extremely high volume, and I'm very pleased with the work and the effort that the team has made to be able to do that work very timely. Overall, this was an increase of almost 600 from the 2017 to roll, as we had placed 5,900. So, Mr. Chair, that completes my report, and I'm happy to answer any questions.
Thank you. Mr. Juarez.
Yeah, I just want to take a moment to compliment the staff. I did attend the Sacramento event, and it was very well done. The presenters were great. A little crowded, but that's a good thing, I think. And I just want to again commend you, Donna, and the staff. Just did an excellent job the way they covered the landscape of the many, I think, very just very difficult issues that members face as they get ready for retirement. I thought just did an excellent job. So again,
thank you.
my kudos.
And thank you for attending.
Yeah.
Thank you. Seeing no other, pardon me, Mr. Miller.
Yeah, I would just also echo those sentiments. Very well-coordinated, systematic approaches to the event, and just the kind of, I guess I would call it, representation of that customer service culture that you're trying to develop was really evident in watching the interactions of the staff with the members, and I just couldn't be more impressed. Thank you for that opportunity.
And I too was, as you mentioned, I was there, and I was impressed with the fact that the common room, the vendors room, was so much wide open this year that people actually didn't have to bump into each other to get around, and they actually were having a good ability to have good conversations with folks. And then as I left the room, I see there's 25 people standing in line for the next class because that's how full they were. So that was a good thing to see as well. So great job, especially since you had an entire volleyball tournament going on downstairs at the same time. That was impressive.
Well, one of the challenges that we do have with the Sacramento Convention Center is we are outgrowing the capacity of even their largest rooms. And so as we are planning going forward, that's something that we have to look at in terms of the duration of the time that we have here in Sacramento for the event, and then the possibility of trying to expand within the convention center as well. But it has been a challenge, and as I mentioned, we did have a few difficult challenges as we were planning for it. But as you experienced, the work effort really was done well, and I do think that you all and our members had a very good experience.
Great. Thank you. Ms. Bailey-Crimmins?
Good morning, Mr. Chair and members of the committee. Leanna Bailey-Crimmins, CalPERS team member. I second Donna's sentiments, and I would like to congratulate Mr. Fechner and Ms. Taylor for their new positions as chair and vice chair. And I look forward to working with you and the rest of the committee members on having a successful 2018. For my opening remarks, I have 3 updates. The first is the Dependent Eligibility and Verification Project. For this month, CalPERS will be working with employers to validate dependent information on file for 2 groups. One are the active state members, and the other is the active CSU members. The second update that I will provide is that the government recently did pass the funding bill we talked about in December, and there were specifically health-related taxes that I'd like to provide you an update on, what specifically the CalPERS team monitors. And then lastly, as we've seen, the national influenza epidemic, OptumRx has been very proactive, even though there has been a shortage of an anti-flu drug called oseltamivir. And so I'd like to talk to you a little bit about what our members will experience when they show up to get Tamiflu. For the Dependent Eligibility Verification Project, we have done this project before. Again, it's for the state and CSU members only. The employers will be responsible for collecting the information and verifying dependents' eligibility. Members will receive a series of notification letters. It is through a 3-year cycle, so once that 3-year cycle stops, then it will repeat every 3 years thereafter. The first notification letter will be 90 days from the validation date, and then a reminder letter if we have not received the information 60 days in. And then as we get closer to the 30-day mark, there will be a last cancellation reminder letter at that point. But something of this size we know requires communication. It is vital to the success to reduce confusion and streamline the process. And so therefore we have worked closely with CalHR and the CSU to develop procedures to assist employees and employers, including basically frequently asked questions to help kind of navigate that process. Also, CalPERS published in the Perspective both the fall 2017 and spring 2018 process procedures to help inform our members. And then looking ahead as we get closer to the end of 2018, there will be the Dependent Eligibility Verification Project will expand for state and CSU retirees. As a reminder, CalPERS is the health benefits officer for the retirees, and so we will be responsible for verifying dependent information and collecting those documents. And so as we get closer to that date, we'll be bringing back more information for you. And so for the ACA taxes, there were 3 health-related taxes that were in the funding bill. Good news on all fronts. The good news is the bill extended the existing suspension of the ACA excise tax, also known as Cadillac tax. It pushed it out from 2020 to 2022. So that's an additional 2 years. Also for the medical device tax, that got pushed out to 2020. And then for 2019 only, the bill suspended the health insurance provider fee. And industry experts say that basically accounts for 2 to 3% of your HMO premiums. So this is great news since we're going right into the 2019 rate development process. We'll make sure that those plans are not including that tax. And then lastly, the bill did include a 6-year extension on the Children's Health Insurance Program, also known as CHIP. It provided an additional 4 years of CHIP funding for a total of 10 years. The loss of CHIP funding would have impacted 1.3 million Californian children. And the funding for CHIP and other federal health programs is important to CalPERS. It was great to see bipartisan agreement on a health bill. Also, we see that it would have impacted commercial market as well, and we obviously want to make sure that our most vulnerable population of children are being taken care of. So good news on all fronts there. Not so good news, the national influenza epidemic. There has been a supply shortage of the generic anti-flu medicine, as I was mentioning, oseltamivir. And what this means is that only the brand version of Tamiflu is available. So typically when you pay for a name brand, you pay a higher copay. Our pharmacy benefit manager, OptumRx, took a proactive approach to address the severity of this issue, and Tamiflu will now be available at without the brand name price. So that's a great thing to address this. They'll continue to stay in effect until the shortage abates and or the flu season ends, which they're expecting to be approximately the end of May. It is important because in addition to the influenza-related mortality, recently published research indicates that this year's flu vaccine is estimated to be only 10% effective against the predominant influenza strain. And as such, this means there's a likelihood of increased utilization of drugs such as Tamiflu. So this is a very important note. And PHBC's agenda is fairly comprehensive today, but two highlights. Just letting you know, PPO and value-based insurance design improvements have been made. We have worked with the stakeholders and did quite a bit of outreach, so what you will see today is improvements based on that input. It is an information item, but we'll be coming back to you in March for a decision. And then as requested at the November PHBC, the health program is going to provide an OptumRx improvement update. And you will see that the data provides significant improvement, but we also want to make sure that that does not mean that there are not additional areas of improvement. Whenever there is a concern of our member escalated to CalPERS, we treat it with the utmost importance, and we look for opportunities to make systemic improvements that improve all of the system for all of our members. So with that, Mr. Chair, that concludes my opening remarks, and I'm available for any questions.
Very good, thank you. Seeing none, we'll move on to agenda item 4, the consent calendar. Item 4A and 4B is the approval of the minutes, and in option 4 form, what's the pleasure of the committee? So moved by Mother, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 5, consent items. I have no request to remove anything from the information consent items. So we'll move on to item 6, proposed regulation for definition of full-time employment. Ms. Ostrander.
Good morning.
Morning.
Renee Ostrander, a CalPERS team member. Before you today is agenda item 6, the proposed regulations which define full-time employment for purposes of determining CalPERS membership eligibility, reporting overtime positions, and determining compensation earnable and pensionable compensation. The board originally adopted a resolution in 1932 defining full-time employment. It's then been amended a couple of times, with the most recent being in 1980. With that resolution, the board adopted a minimum and maximum full-time work week and states that the individual contracting employer determine full-time employment for its employees. The proposed regulation before you provides multiple benefits. It further solidifies the board's current position as a regulation, a step in strengthening the position already established, continues the practice of the individual employer defining what is full-time, and it removes the maximum cap to provide flexibility for our employers. We've seen some changes over time in employers' practices. For example, our firefighters that work a 56 or a 72-hour work week. The removal of the cap allows the employers flexibility in developing what constitutes full-time for their agency. To address any potential perceived conflicts between the current board policy that is transitioning to this regulation and the statute, we've included a sentence in Section A of the regulation. The section states, "This regulation does not apply to the extent it conflicts with a provision in the Public Employees Retirement Law." It goes on to cite the example of Government Code Section 20636.1, Section B1, which is related to payroll reporting of classified members at school districts. The schools will not be asked to change any of their current practices of reporting. If the board approves the proposed regulation and the initiation of the regulatory process, staff will request the publication of the notice of proposed regulatory action in the California Regulatory Notice Register. As part of the notice of proposed regulatory action, a minimum 45-day comment period is required. At this time, we do not have a public hearing scheduled for these regulations. If we receive a request to schedule this from the public prior to 15 days before the close of the comment period, we will schedule a public hearing coordinated with a future Pension and Health Benefits Committee meeting. This completes my presentation. I'd be happy to answer any questions that you have.
Thank you. First of all, I want to thank you for the clarification on the school piece. Been hearing a lot of questions since your stakeholders meeting, so I'm glad you cleared that up for everyone. What's the pleasure of the committee? Moved by Jones, seconded by Mother. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you.
Thank you.
Now moving on to the information items. Item 7, public agency recruitment and retention for health benefits program. Mr. Drzombeck. Other side, probably. There you go.
There we go.
Well, he's on.
All right, good morning, Committee Chair, and congratulations on your appointment. And Vice Chair, congratulations on your appointment as well. Good morning, members of the committee. Rob Jarzamba, CalPERS team member. I'm presenting this information item as an annual update on the health program's public agency retention and recruitment efforts. Today, I'll focus on 3 areas: our 99% retention rate in 2017, new information about an untapped market of potential contracting agencies, and our marketing team, which may be small but is mighty when it comes to competing in the very competitive health insurance marketplace. A few years ago, there was an effort to expand public agency and schools marketing, and this was part of the 21 initiatives. In response to the request made last year, we have an update on our marketing efforts. With the health marketing team, again under the Chief Health Director's leadership, we're identifying new areas and opportunities to recruit public agencies and schools and retain existing ones. As many of you may know, the CalPERS Health Benefits Program has over 1.4 million total covered lives, or TCLs. These TCLs are comprised of employees, annuitants, and their families. The majority are from the state, and 41% are from public agency and school employers. The health program continues to grow, as you can see from this 10-year chart. Over the last decade, we have gained over 177,000 TCLs, which equates to almost 18,000 a year. What's important to note is that this growth occurred during a period of significant change in the health marketplace. We experienced the recession in 2008. The ACA was signed into law in 2010. The California Healthcare Exchange began in 2014. And we saw the advent of high deductible plans that have gained interest amongst employers. Even through these dynamics, we've still added TCLs, demonstrating that both employers and employees appreciate the high-quality health benefits and value that CalPERS offers. In 2017, we again achieved a 99% retention rate of our contracting agencies staying with us. Agencies stay with us for a variety of reasons, many of which are the same reasons that make us competitive in the marketplace. For instance, we do not charge any broker fees. We maintain a very low administrative fee, which is currently just 0.33%. And by statute, this fee cannot be more than 2%, and we've never come close to that. Brokers, on the other hand, can charge from 1% to 3% or even more. We don't require 100% participation. We have the largest risk pool in California, which makes us a leader. And we announce our benefit rates and changes in June, so both employers and employees can plan for the following year. While there are significant advantages, the health marketplace is still very competitive. Our small but mighty marketing team regularly meets with employers, labor groups, and management across the state, as well as attends many conferences. We compete for business against private sector brokers that have very deep pockets, which at times can make it very challenging for our team. Additionally, brokers use a wide array of tactics to discourage agencies from contracting with us or lure current ones away. These tactics include regularly sponsoring receptions and giveaways at conferences, interrupting our presentations at employer locations, and misleading decision makers and employee groups by providing incorrect information about the CalPERS Health Benefits Program. I'd like to share a quick example of what happened last year that illustrates the competitiveness in the marketplace. During a health enrollment event for a new contracting agency, the previous broker set up a table and brought in a team to sell their health benefits to our members. We repeatedly asked the broker to leave, and advising them they could not sell their health insurance at our health enrollment event. After a lot of back and forth, they eventually did leave, but they certainly didn't go quietly. Now, despite our competitors' best efforts, last year we brought on 10 new public agencies and 9 new employee groups from current contracting agencies, which account for over 6,000 new TCLs. We did, however, lose some agencies, and those are outlined in the agenda item. For 2018, we have already brought on 5 new public agencies, including the City of Inglewood, which is returning to us after over 10 years. According to the city, they plan to save $4.5 million in their first year with us. In the end, despite what brokers may do, our team is open, honest, and professional when it comes to our interactions with employers. We've received thanks and kudos for assisting them and explaining the complexities of health insurance to both current and potential customers. Recently, we partnered with the state Social Security Administrator, and we now know there are approximately 5,642 employers available to participate in the CalPERS Health Benefits Program. This untapped market is a huge opportunity for CalPERS. Having this data and contact information will help us better target our outreach efforts. We also know there is a subset of these employers that already have a CalPERS retirement contract with us. These agencies already know how to do business with us and know the value that CalPERS brings to their agencies and their employees. We plan to create a special marketing campaign to focus on them. For next steps, we are developing an outreach campaign to establish ongoing, regular communication to raise awareness of the CalPERS Health Benefits Program. These activities include partnering with the state Social Security Administrator to market to the over 5,000 agencies I just spoke of, increasing our level of attendance at conferences so we may increase our exposure to new agencies, continuing to conduct health workshops at regional offices and the Ed Forum so that we may meet face-to-face with employers and answer their questions, and developing new and targeted marketing materials with the assistance of public affairs. Overall, the CalPERS Health Program is strong. We continue to achieve a 99% retention rate. Our small and dedicated team of marketers achieves results year after year. And we have an excellent potential for growth through the untapped market of public agencies. This concludes my presentation, and I'm happy to answer any questions.
Thank you. Mr. Juarez.
Yeah, I have a couple of things. One is, you mentioned Compton coming back into the program after 10 years, and then in the write-up there was an example of San Luis Obispo County, and they were very explicit as to why they left the program. And I'm wondering if, and the reasons why, and whether or not we could address those issues that they raised, and whether we're going to attempt to do so in the future in order to draw them back in at some point.
Mr. Juarez, just to let you know, one of the things they cited, which we discussed, was the regional volatility. The other northern region had a 40% increase. And so what we're doing is over the next 12 months looking at the total cost of care across all counties and seeing if there's any changes either in the regions or the regional factors that would help employers that have these ups and downs, which is very difficult for them to budget, and it's also difficult on their members to be able to budget for within their household. So we are looking at that, and we will be bringing a recommendation back to this committee in December.
Okay, thank you for that. The other issue was, as I was reading the item, it said you noticed that the total covered lives is greater going out than coming in for the last year, and I don't know whether that is historical, whether that's an aberration, and so I'd like to get just a sense of how that stacks up about what we've seen in the past and whether what we see in the future, I guess.
That is different than what we've seen in the past. This is one of the first years in recent time where we have had a few more lives going out. However, with the new agencies we brought up in 2018, it is still a net increase to the program.
Okay, thank you.
Ms. Taylor?
Thank you, and thank you for the report. I was just kind of wondering, and I think Mr. Juarez asked part of the question I was going to ask. As we are seeing some of our agencies leave, and it seems to be apparent they're leaving because of regional issues, and you're saying it's an outlier. As we consider our regional rates and stuff, is this going to, hopefully, are we working to help mitigate this issue of the regional issues? That's where my concern is.
Spot on, Ms. Taylor. It was 13 years ago where we established where the lines are drawn. And so we believe, and one example I've given is just Stockton historically. Stockton over the last 13 years, we know San Joaquin County has more hospitals, more provider networks than they did 13 years ago. And we owe it to our employers and our members to at least every 5 years look at the total cost of care and bring that back and see if there should be changes. In addition to regions, within a region, the HMO carriers are able to establish they use their actuary formula for the regional factors. And so we will be looking at opportunities to, now that we have multiple carriers, how do we provide more direction to them on how they do the calculation? And then based on that, the big thing for us as an employer is just the volatility that's creating the issue. I mean, everyone expects potentially a little bit of an uptick every year, but when you have it go up or go down, it's very difficult for the employers. And so we really need to look at the data and then based on the data, provide you a good recommendation so that we can see how we can help these employers in the regions.
Are you seeing, I don't know if we know where, for example, is San Luis Obispo going to a high deductible, low cost plan? Is that what they're, because then that's sort of out of our realm other than our PPOs. But is that, are they mitigating costs in that way, or are they getting a better deal? I would imagine it wouldn't be much different, but if they were to seek the same type of insurance, but if they're looking for something that we don't offer, there's where we would sort of, yeah.
So employers do look at, we have seen where employers believe a high deductible is the best option for their members. Statistically, that isn't necessarily the case. Actually, as we're starting to see where employers are leaving, many are coming back because what happens is then your employees are making a decision on what they can afford. So do I pay the deductible or do I get the care? And we want people to get the care because then they're healthier, they're more productive employees when they show up for work, and it's just an overall better, healthier system. So I think part of it is also educating employers that CalPERS offers choice, competitive choice. And based on that and based on what's in the region, we bring things to the table that others may not. And what I find is many times the brokers will lowball, get them in, and then they are in a situation where now it swings way up. And because of our regulations, they have to stay out of CalPERS for 5 years in order to come back.
Right.
And so if they make the wrong deal and then they're in the situation like we heard of City of Inglewood, where now they're coming back, we just want to make sure we're giving the employers as much education as possible. Ultimately, it's their decision, but our job is to make sure that they're making a data-driven decision for their employees.
Part of our education process is also advising them on some of these outlier plans, the high cost, low deductible, because it does drive higher costs in the long run. So when we're educating the employers, we're also, I hope, doing that, because I know that seemed to be an issue last year where we lost some of the employers and they were saying they wanted choice of that kind of a plan, and we don't offer that except for our PPO. But so that's where my concern lies, is that it ultimately drives everybody's costs up to do that kind of plan, but in the long run, it's more helpful to do our HMOs or our PPOs that we offer. So I'm glad you guys are doing education. I appreciate the report, and it's good to see that some are coming back in. Thank you.
Thank you. Before I go to the next person, in your professional opinion, how many, if any, and you may not know, but it's nice to say they're a regional issue or it's a cost factor, but how many of them do you think is the underlying issue to escape paying for retiree health care?
So according on the attachment 2, there is some of that concern. We have 1, 2, 3, 4, 5 that have been cited out of all those that we lost, that was one of their concerns. So yes, that is still an issue.
sadly, but thank you.
And Mr. Fechner, also part of it is education. I believe they have to cover the retirees if they're part of CalPERS, but there are options.
Correct.
And again, this comes down to sitting down and having the conversation that they can cover retirees and them, but they have flexibility within that. And so I think it's just getting out there to make sure that they have accurate information on what they can include in their resolution with CalPERS and still be a part of the system.
Correct.
Thank you. Mr. Miller.
Yeah. In terms of those 5,000 plus prospects, could you talk a little bit about your expectation of likelihood of being able to successfully engage them? And I don't know how much of a profile of them your team's been able to put together, but what are the kind of key characteristics or factors that you would say are the things that lead you to think that you can really penetrate that potential market? What would characterize those prospects?
Well, I think that, so we haven't begun that yet. We're just starting our partnership with the State Social Security Administrator. It's underway right now, actually. I think some of the key factors that I shared on like how we are better, on the significant advantages we have, the low administrative rate, 100% participation is a big deal, where some brokers require every employee to have their health coverage, even if they have coverage with their spouse through other means. Our admin fee is extremely low. We are the largest risk pool. So those it kind of sells itself. What we need to do is try to really get out there and get to those right decision makers and those employee groups who do make those decisions and do want better health care and a better value. So that's what we're targeting. Especially with those who already do business with CalPERS on the retirement side, we think those would be they're more aware of us and know how to do business with us and know the value that CalPERS brings to both their employees and their agency. So that's where we'd like to start. But there's a lot of different pockets that we can look at, and we're looking at them now to figure out how we can best do it, and then also do it in a way where our team can still provide that excellent customer service and outreach and education, so we're not bombarded and we're leaving people where we can't actually respond to the demand.
So on the flip side of that, where do you see the challenge? What are the primary objections or obstacles, and how are you going to target what you go after first? Would it be things like rural areas where there's been big changes in that marketplace and availability of providers? Would it be their financial structure the way it is now with their health care? How do you see that?
We're really just starting to look into all of that to figure out what will give us the most bang for the buck, if you will. And so I think that we're probably start with some level of current contracting agencies on the retirement side, and then there's also the potential to grow with other employee groups within an agency. The problem there is we don't know how many other employee groups every employer has, and so but by doing that, there's also potential for growth there. So we are just still figuring all that out on what to do first and when, but we'll definitely want to take advantage of this new opportunity.
Yeah, thank you, sir.
Thank you. Ms. Mother.
Thank you. I just want to make sure, I have a couple of comments, but first a question. On attachment 1 for 2017, I thought I heard you say that we had 9,000 new total covered lives come in, but this chart says that that's how many we lost. Did I misunderstand?
I may have misspoke. For 2017, we lost 9,000.
Okay.
And then we gained almost 6,000, 5,900. But then so far for 2018, we've gained 9,000.
Okay.
So despite that fluctuation last year, we still are at a net increase.
We're still at a net increase between the 2 years.
Correct.
Thank you. That's helpful clarification. So obviously you focus both on recruitment of new agencies and on retention of our existing agencies. And do you have a sense of what the split is between the resources that are dedicated to those efforts?
So we spend about 20 to 25% of our time on retention. Mm-hmm. And so that's going out to different employers and talking with their employee groups or their management teams when they're thinking about going someplace else. Or a broker has approached them, say, hey, we can give you a better deal, here's why. So we do spend, it's a regular part of our workload. Then the rest of it is outreach for the new contracting agencies and then bringing them actually on board.
And what do we do proactively before, say, a broker has approached an agency that's within our pool? Do we have a sort of a proactive relationship management effort going on?
We do. We do have a small team, though, I should note.
Yes, I know. I recognize that. That's why.
Each year we do have health workshops at each of our regional offices. So that's a regular thing that happens like in the July-August timeframe, where we meet with them and talk through all of the changes that are coming for the following year. So that's our most regular outreach effort for retention to ensure everybody knows of the changes. We also do get special requests for us to come visit the employer agencies, so we will gladly do that, to come talk with them, whether it's on the recruitment side or retention, to make sure everybody's aware of what they can do, and if they want to change some of the benefits or change their resolution, we can work with them so they can do that as well.
I guess what I'm getting at is it seems like, I know you have a very small team, and it seems like there could be a sort of pretty significant return on investment for each additional marginal resource that we have in this group, that the benefit to the pool as a whole and to our existing members as well as to the new members we might bring in is significant, and that perhaps it's and I know we're thinking about this, but I think it's worth considering what would be the optimal size of a team to really have a robust retention effort where employers aren't even, for the most part, enticed by other brokers, or that they feel so confident in the service that we're providing that they're not that we don't have a significant risk of departures, and that you can have a really effective recruitment effort. Mm-hmm. And I guess I would like to know what that would take and what we think the value add would be for those additional resources, because I do think that this is an area where we could invest a fairly small amount and have significant gains. That's my suspicion.
And that's something we'll definitely take back and look into and report back.
Terrific. Thank you.
Thank you. Mr. Jones.
Thank you, Mr. Chair. I have two questions. The first one is, you refer to groups in here, and is that like classifications?
That's like bargaining groups, so like group 1, 2, 3, 4 are the different employee groups who may have been hired after a certain date, or miscellaneous versus safety. It's a variety of different ways.
And so some of them I noticed go up as high as 37 different groups in one agency?
That 37 was for all of those 10, I believe. So there's amongst the 10, there were 37 groups with them that came on board.
Okay. And my second question was triggered by this statement about successor agency to redevelopment agencies of the city and county of San Francisco, and what triggered the question on JPAs, joint powers agreements, and we've had significant issues with the pension side for employees in those agencies. And so my question is, do we have joint powers agreements that are providing health benefits to their members, and if so, have we reached out to be sure that the sponsoring agency is providing coverage in terms of liability for those costs?
That's an excellent question. I'm not exactly sure. I'm confident we do have JPAs that contract with us. Okay. As far as have we reached out to make sure their funding source is
being
sound
by the sponsoring agency.
Right. I'm not sure. Health does work a little bit different than retirement, where it's more pay as you go versus you have this big liability. So there is less of a risk to the employees and to the employer. However, it's still something that we need to be mindful of.
Okay, yes, I think it's important because we had a lot of discussion about how to deal with that on the pension side. So I think we need to look at it on the health side.
Hi, Renee Ostrander, CalPERS team member. Yes, exactly what Rob was talking about is that since it's a pay-as-you-go, so if there's any issues with the JPA and there's a non-payment, then it's just they cut the benefits going forward. So there isn't a continued loss like you'd have with an actuarial liability that would accrue if we don't receive the funds that we need for that year.
Yeah, right, and I understand that, but the final impact is the employee loses their health coverage.
Correct.
And the sponsoring agency needs to be held accountable for providing that if they're the sponsoring agency for that JPA. Okay? Okay, thank you.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. Just to build on what Mr. Jones was saying, not only loss of health care for actives, but the real problem is on the retiree side. And so that's, I think, where that liability can come into play. So bear with me a moment. I'm new to the committee, so I've got a couple of questions on this issue. One is, you talked a lot about broker behavior, and the implication of your comment is that that whole segment are bad actors. And I just want to make sure that we understand there are people who are ethical and appropriate and do the job well and compete in an appropriate manner. I assume you would agree with that.
Yes, absolutely.
Okay, good, because you didn't talk about the good actors, you only talked about the bad actors. In attachment 2, page 1 of 1, on the agencies that have left, some mention more high cost, but they also mention OPEB liability concerns. So I'm not sure I quite understand why moving from CalPERS to somebody else could positively impact OPEB unless they're just going to get lower cost going forward.
So what this means is that with the CalPERS health program, there is a retiree requirement, and so we do have to. Employers do need to cover retirees up at some point, to at least at some level. And so without that, when they go to a different broker, there is no retiree requirement. And so then all the retirees are basically...
So reduces the OPEB liability.
Correct.
If they suddenly decide we're not going to cover
correct.
retirees,
So
or we're going to cover them with a less expensive alternative.
Correct. Or they're only going to cover their actives.
Okay. All right. At the scale we're at in terms of the number of covered lives we have, I understand that we always want to grow and add agencies. I'm not sure I quite understand what the net benefit is to the people who are already covered because the scale we're already at. So if we add another 10 agencies, another 9,000 covered lives, does it actually move the needle in any respect other than, we added 9,000?
We get to say we're larger, right? So that's an excellent question, and that really comes into our ability to negotiate with our plans and to bring new benefit designs to our members. And so it's seen that way. It's maybe not as tangible as we'd like it to be, but that's where we can really. That's where we're really trying to make sure we're still a leader and to be able to negotiate better rates for our members and employers, as well as have the benefits that that we think they need.
But if you have how many covered lives? We have 1.4. 1.4 today. So if you add 10,000 next year, does that really impact our ability to negotiate with the carriers?
Yes.
It does. Okay. All right.
The carriers would love those lives, and also it's one of the things coming into health is understanding when we talk about members on the pension side is the employee. For us, when we talk about members, is the total cover lives. So you take that 1.4 million, and an average family has 2.5 people in their family. That's really not that many employees. And so there's just a big opportunity here where many employers do just pension business with us and do not do health. And I just think it's definitely an opportunity. And at some point, you're right that there is a scale, but I think the more of those lives, it does equate to when I'm sitting across the table from the plans, they're really interested in getting more.
Okay. So the 5,700, whatever it is, agencies in the database that are possible, how many of those are in the pension system?
So we don't know that figure exactly. So the way they're counted is different. So for the so for instance, for COEs, the County Offices of Education, they have their contract with us, but then, and they have one contract for pension with us for all of their districts, whereas the schools would have, each school district would have their own health retirement contract with it. So we tried to make that comparison to get that, but it's an apples and oranges, so it's never going to add up.
Right. But I assume that you would, if again, total covered lives is the objective to grow the system, that you would start with the largest and work down rather than start with the smallest and work up. So my question is, when you get to large employers. So my coverage is through SMUD, and SMUD is not in the healthcare. I'm sure you'd love to have them in. So for SMUD and for other large employers who have some scale and obviously can negotiate and have several thousand lives that they're covering, besides the issue of retiree health, so SMUD provides full retiree health, what other reasons for these large employers are they resisting coming into CalPERS?
I think some of them may already just their employees like what they have. It's a good program. They feel they're in a good position too, where they're able to negotiate good rates as well. I'm not sure all the specifics. I think everyone is different, and that's what we're noticing when we go out there. Every bargaining unit is different. Every employer is different, and so that is part of the challenge that we face when we go out there. It's not a one-size-fits-all for all of these employers, and even within an employer, all the different groups that may be in there. So I'm not sure how better to answer that question.
Is part of it just having control? Kind of, the concept of local control. So as opposed to being part of a large pool, I now have the ability to custom design the plan to negotiate. Maybe I want this feature and CalPERS has these 3 features. Is that a big part of it, the ability to kind of design what you want?
It could be, possibly, but however, that is also a workload. And so that is something that they need to have their own people. They're paying somebody to do that. And so we have a fabulous team here that's doing that and does it at a very competitive rate. So again, it's really individual to each agency.
Well, they're right down the street. So.
They are. We know.
Okay. Thank you very much.
Thank you. Mr. Gillahan.
Thank you, Mr. Chair. I have a couple of questions. I'm referring to the same table that Mr. Slayton was referring to regarding the losses. And one of there's sort of groupings of reasons why, and one says high cost and OPEB liability concerns. In that grouping, are those employers telling us they want a different plan design, such as a low-cost, high-deductible plan?
It's either that or it is the regions that we've been discussing, yes.
Okay. And where it simply says seeking more flexible benefit package allowing lower premiums, is that in reference to a low-cost, high-deductible plan?
Correct.
So, and I believe in prior years we've been hearing this as well from our employers. So the reality is if we don't offer it, they're going to go get it somewhere else. With regard to scale, I don't think it's particularly provided us the leverage we had hoped to drive costs down or contain the escalating costs year over year. And I wonder, pursuing more scale, what that does to the quality of services delivered to our members. We have a stack of letters from a lot of unhappy folks with respect to our pharmacy benefit manager. And I wonder how adding thousands and thousands of more people into the mix helps that problem in any way. And then I just had one last question. I heard Ms. Taylor say, I think I heard Ms. Taylor say from the dais, and I saw staff nodding in agreement, that a statement of fact that low-cost, high-deductible plans ultimately lead to higher costs. And I just wondered, do we have any data to support that? Is there objective studies that say that? And if so, have they been submitted to the board for review?
There is studies out there of high-deductible plans not promoting healthy actions on behalf of members of the system, and so we would be happy to bring that back at a later time.
That's a different issue than drives up cost.
So drives up cost to the system?
That's what I thought I heard. And I believe Ms. Taylor made a statement to the effect that low-cost, high-deductible plans ultimately lead to higher costs, and as she was making that statement, I saw staff nodding in agreement, so I was just asking if that is in fact true and if we have data to support that.
So the data is that if people are not getting treated early on and doing preventative because they believe their deductible is too expensive, then ultimately it costs the system more, especially since the system of CalPERS handles it from cradle to grave. You either pay now, you pay later, and so later usually equates to a lot higher dollar amount. So we would be happy to bring back some of that information to you.
I would like to see that. In addition, it's my understanding that most low-cost, high-deductible plans that preventative care is not included in the deductibles.
Not always.
But nothing would prevent us from structuring a plan where preventative care is not part of the out-of-pocket expense.
We are bringing to you on a later agenda item the PPO, where we are increasing the deductible and promoting value-based insurance design, where we are incentivizing value-based items. And so we believe that that is, to some degree, exactly what you're talking about.
Thank you.
Thank you. Ms. Mather?
Thank you. I recognize that I think this is a fruitful area to explore whether scale really adds value. I think for us, our members are not concentrated in one place. In some regions or some zip codes, having more concentration would actually mean better leverage in that area, either for the plan that we contract with, or for us with the plan and the providers. Because if we only have 10 members living in seeking care from a particular provider group or hospital, that's not going to really move. We're not going to be able to have much leverage. But if we were to get a new employer located in that jurisdiction and bring in 300 members, that might be a more significant share of that medical group's patient load, et cetera. So anyway, I think it's not as simple as saying we have 1.4 million members. We have 1.4 million members distributed across the state. Thank you.
No, that is a great point, Ms. Mather, because when we look at the regions, some health plans have a small number of bodies, and when they have a high number of claims based on the low number of total cover lives, that does drive premiums sometimes up. And so having more total cover lives in that specific area would reduce cost.
Thank you. Mr. LaFaso.
Thank you, Mr. Chair. Thank you. Actually, I was going to raise the same issue that Ms. Mather did, but I'll just take it one step further. Have we thought of targeting some of our outreach to look at those areas where we might get a significant synergy, where if we added new lives in a geographic edge of our program, we'd improve our ability to retain the people already there and make the coverage area and the service more robust in that particular area? I'm wondering if that's been a retention focus or an outreach focus.
That hasn't been as of yet, but we definitely can add that, and it does work well with the regions discussion we're having as well.
Appreciate that. Thank you.
Mr. Miller?
Yeah. Is it fair to say that the prospects who are most interested in these high deductible plans would likely be the ones who are concerned about costs for their actives, but don't have a concern for the retirees because they don't plan to cover them, and that would certainly make them the natural objectors to a plan that requires coverage for retirees, and ergo high deductible plans would be attractive to them, but not to those who have to actually take care of their retirees.
Well, that's an excellent point.
Yeah, Mr. Miller, so when we bring back the high deductible to the system and to the members, I'll make sure that we do the data against the retirees versus actives, and so that we can see if that's maybe what's driving some of the decision making on the employer side.
Thank you.
Thank you. Ms. Taylor?
Yes, thank you. I just wanted to reiterate Mr. Gallagher's point of, yeah, it would be good to have that information about the high deductible, low cost plans in terms of the cost drivers, because ultimately it does do cost shifting to the employees. Our plan, notwithstanding right now, as we continue to construct the plan, is a little bit different. But generally speaking, high-cost, low-deductible plans are a cost shift onto employees, and I have read many reports that have stated that employees or members of those plans wait to get service until they're so sick that the service costs a fortune. So I think it's something that would be advantageous to have, as well as Mr. Miller's information on, well, if that's the case, then they obviously don't want to pay for post-retirement benefits and that makes sense. So it is important that we do that, and I know that I opened that up. But then my other statement is that I think it's also important to remember we have a regional issue. We have rural counties where healthcare is very high cost, and as Ms. Mother said, if we get more members in these regional areas, that gives us the benefit of being able to push these small hospitals for better costs and the small doctor's offices, et cetera. I get a lot of complaints from my members that they have to travel forever just to get care. So if we have another 300 or 1,000 people in that area that we've recruited, then we have much more leverage to tell these hospitals that are closer to these members that they need to bring their costs down. So, thank you.
Thank you. Seeing no other requests, thank you very much.
Thank you.
Brings us to agenda item 8, CalPERS PPO plans, optimizing healthcare benefits and outcomes. Ms. Donison.
Good morning, Mr. Chair. Congratulations. And Ms. Vice Chair, congratulations. Kathy Donison, CalPERS team. This is agenda item number 8. It's a continuing update to you on the work we've been doing on value-based insurance designs for our PERS Select, and also to update you on additional work that we've been doing in looking at PERS Care and PERS Choice. So for the agenda today, I'm going to talk about, I'm going to remind you of some of the history of how our PPO plans were developed. We will then look at some population health statistics, which I was asked to bring back, and I think you'll find some of those findings pretty interesting. I would then like to speak to PERS Care and PERS Choice specifically in terms of its design, and then discuss the CalPERS the design of PERS Select as a value-based insurance design, and then discuss next steps. Joining me today is Dr. Laura Clapper. She is the Provider Enablement Medical Director for Anthem Blue Cross. Thank you, Laura, for joining us. This is the current plan design. It's for the PERS Choice, PERS Care, and PERS Select plan. As you can see from this plan, PERS Choice has an 80-20 type of plan design, PERS Care a 90-10 plan design, and PERS Select an 80-20 plan. Thinking back to the development of these self-funded plans, PERS Care was the first plan introduced in 1989 as a self-funded plan. In 1993, PERS Choice was then introduced as an alternative to the PERS Care plan. And in 2008, PERS Select was introduced as a narrow network plan, both for providers and hospitals. And you will note that there was even a sub-design within PERS Select that if a member went to a Tier 2 hospital, they paid more cost share in terms of using that hospital. Of interest, actually, and I want to thank the committee for asking us to do this. If you look at this chart, it provides for you our top 6 disease management programs we've been running for almost 2 decades. So we've been working on reducing prevalence of chronic conditions and improving the health of our members for a very long time. But you can see that in this design, there was a significant migration of members to the PERS Care product, and the average age has been reduced, and the prevalence of these chronic conditions has been reduced. And this is a result of simply the migration of 9,000 members from PERS Select and PERS Choice to PERS Care. So as the membership increased, the age dropped, and the prevalence actually dropped as the denominator got larger. But I do want to add, in looking at this table and these 6 conditions, we are going in the right direction. So between 2013 and 2017, you have seen prevalence decrease. I will note that depression still needs some work, and this is good for us to know because we'll go back and continue to work on that specifically as a chronic condition. I do want to talk just about PERS Choice and PERS Care as a plan design. We went back between December and today and re-examined the plan design. And so in many instances, we reduced the deductible in Care and Choice. And we also retained the copay as a $35 copay for the urgent care and specialty care. So we, for the deductible, when we look at the chart later on in this presentation, you'll see that we did hold the PERS Choice deductible the same as it is today. And the PERS Care, when we get to that chart, we actually increased it because that's the value of a 90-10 versus an 80-20 plan. Now let's move on to the value-based insurance design, which is I will focus on for the remainder of this presentation. We've been working on a value-based insurance design for nearly 2 years, and we've had expert speakers come out and talk to us. And over the last year, we've really looked at a design that's specific to CalPERS. I won't repeat all the presentations we made at off-sites and prior presentations to this committee, but this does show the length of time that we have been working on a value-based insurance design for PERS Select. Now, why did we take this journey for a value-based insurance design? We did it primarily because in our PPO population, there's a lot of choice for our members. They can choose one of 3 plans. They can choose to go straight to a specialist. They can choose to go to a richer benefit design should they wish to pay the premium. So the idea behind the value-based insurance design was really to promote physician engagement and member engagement. And we've built in some incentives to get our members to do some of the evidence-based engagement that makes sense. And Dr. Laura will talk about the importance of that from the provider's perspective in a little bit. So what we did is we took our deductible. If you look at this chart, you can see that in the VBID, the PERS Select, we reduced the individual deductible to $1,000 from what I previously presented as a single deductible. And then we identified 5 incentivized activities for our members to do to engage in their health and wellness, to take some, to engage with their physicians in things that we believe are preventative health and wellness activities. And if you take those 5, which we have designed to be very easy to achieve for any member in this plan, it takes the deductible right back down to the current $500. We believe in the value rather than just the cost implications of this plan. And I think Dr. Laura is going to be very helpful in explaining from the provider perspective why what we have designed is important in terms of physician engagement. But I do want to point out one other aspect of this program, and that is for expectant mothers and babies prior to delivery. If a mother engages in the Healthy Mom Baby program, then those deductibles, that 20% coinsurance is waived. So we really believe that the health and wellness of our mothers is important, particularly in the rural areas, and that is one of the advantages of engaging in the PERS Select program. We also think that if members engage and babies and mothers are healthy, then it will also help us address the C-section rate. Before turning to Dr. Laura, I just want to restate why we believe value-based insurance design is important as a direction. One, it's an innovation. It is, there are a few states that are progressively moving towards this, and CalPERS is among that mix of really thought leaders in terms of value-based insurance design. So these are the points that we wish to make in terms of the journey and where we are. It offers personal doctor-supported care. That is, the member has a personal physician that's going to direct their care, guide them to different sites of care, and really engage with them in terms of sort of advanced primary care. Do they really need a specialist? Do they really need a surgery? That's why that's important, those first two. It also, this approach aligns with the Healthier You and Let's Get Healthy California initiatives, which really focus upon health, wellness, prevention, and chronic disease management, and maintaining health and wellness. And then using our 3 plans, you still have choice of the plan, and even within the PERS Select VBID plan, there's still choice. There's choice to engage or not to engage. And finally, it does eliminate that 70-30 tiered hospital approach. That's part of the current design. So now I'd like to turn this over to Dr. Laura Clapper, who's going to talk about this VBID plan from the provider's perspective.
Thank you for including me. I'm really honored to be here, particularly in such a, with all of you who have been thought leaders and really in terms of thinking about how to improve health outcomes and affordability. I think that a value-based insurance design is a really great step towards how do we engage both providers and members in improving care. I think to speak to this about, why should we have something that really encourages members to select a physician and or enroll? We use those terms interchangeably. And what's the importance of that primary care physician relationship? I think that if we all would think back to when we were kids, you all thought about what doctor you would go to. We either went to your family doctor or a pediatrician, and I think with all the different changes and complexity in healthcare, we've many times moved away from that. And I think that when we look at the literature, having that relationship is really important. People have taken different strides about it, really working on patient-centered medical homes, and there's literature primarily in that area about improving quality in the Anthem's ACO program, Enhanced Personal Health Care. We have data that shows that if a member stays with a PCP for greater than 1 year, so obviously that you don't have to select a member in that, you actually can, but you don't need to, it's by all choice. But if we see in the claims that someone's persistently seen a PCP over 1 year, that their costs are actually 2.5% less. And we think that that's from the care coordination, the navigation, someone's making sure you're not getting duplication of services. There's shared decision-making going on because I know you. And so I think that's the kind of relationship and personal care we really want to have for CalPERS members and trying to include in this benefit design. I think that the other thing, and I think to Kathy's point, is physicians that we've been pushing, in my title it says provider enablement. I work on working with our California medical groups and how to improve the care through our ACO program. And they're looking at their data. We have people working with them, how to do outreach, how to do all these things. And I continually am told, what is our employers doing to encourage members to engage with us, right? We're calling them, and a lot of times they don't want to do it. So I really salute you in terms of thinking about how to engage the providers and the members together to improve health outcomes, affordability to the triple aim. And I know you're all familiar, Kathy was talking about how much, we've talked with CalPERS about the triple aim, and this design really encourages both the two people that are most important working together, the primary care doctor and the member, to improve their health outcome. And I think that this slide does a great job of talking about really providing that medical home, the help with navigation, that encourages that ongoing relationship. So you can still go directly to a specialist, but the idea is to really encourage having a PCP involved so you have the care closer to home and having it be coordinated. As Anthem takes really seriously our role as being the PPO provider in the rural counties for CalPERS. And we're continually thinking about how do we provide the same quality of care throughout the state. And so I think there's more that we can do to support primary care doctors when they're involved in the care to help provide the specialist care plan, but closer to home. And I think by getting the primary care doctor involved and a member going to see the primary care doctor, there's going to create more opportunities for us to think about how to involve, or that combination of consultation with the specialist, but getting some of that care closer to home. The opportunity for disease prevention, I think it's not just in terms of immunization and things like that, but all the HEDIS measures, so better diabetes care, that primary care. Kathy's point around depression, that primary care plays an important role in depression identification and treatment. And, Anthem's done a lot of work in terms of our telehealth, and we have the telehealth psychology. So you could see your primary care doctor and then have telehealth psychology if you lived in a rural area. And then bridging between the patients and the healthcare, having engagement, but both of them having aligned engagement. Just move on to the next slide. So I've talked a little bit about this, the member and the engagement, to the 5 behaviors, because it's always scary to make changes, and I know that there's some concerns about increasing the deductible, but I think the important point is that people can earn it back so it stays the same. So you're doing it in a very innovative way. So I think, and continuing your role as thought leaders. So the 5 areas where members, everyone's eligible, and all the deductibles credit for each year. So the biometric screenings, and it can be in person or the packet can be mailed to your house. So trying to take into account accessibility, the preventive flu shot, the non-smoking certification that can be done online, that would be done online, the surgical second opinion, and if you don't need surgery, then you would get the credit, and then participating in condition care or disease management. So if you've not identified, you don't have a condition, you would still earn it. But if we're trying to call you and you say, I'm not interested, then you wouldn't earn it. Right? So either you engage or you don't have a condition, then you would earn the credit. So there's been a lot of thought about what are the right things, making sure that it's evidence-based, that these are the things, that it's not just pure wellness, that it's the combination of chronic conditions and surgical, because we want to support the shared decision-making around surgical opinion. So I think, and really being a good consumer of healthcare. So I think that this does a good job of aligning all those different aspects of total healthcare costs, as well as holistic perspective on the member. And with that, I'll turn the lap for closing to Kathy.
Thank you, Dr. Clapper. We will be coming back with the final presentation on our value-based insurance design, asking you to make a decision on the package of benefits that we have been presenting over almost a year. We would then, as part of next steps, a full engagement, not just with our members, but with the providers as well. And I did raise this design with physicians that attended our last Smart Care California meeting, and they're very excited about it. Oftentimes, the administrative burden in terms of care management, it just seems like it continues and gets more complicated. This is one in which they have a plan design that they can work hand in hand with the patient. We're particularly interested in the idea that it gives you it's not an HMO managed care, but it is an advanced managed care through a PPO product design that will work either in the urban or rural counties. So with that, I think I'll close and take questions, and also Dr. Laura will take questions as well. Thank you.
Thank you. Mr. Juarez.
Yeah, thank you for the presentation. It was very good. I wanted to ask the question, do you need to meet all 5 of the offerings in order to qualify for the reduced deductible?
No, my understanding is you would earn like partial credit.
Okay, so if you do all 5, you get
You
the
do
full
all 5,
credit.
you would get the full credit.
But if you don't, you get partial credit. I'm sorry, Kathy.
Let me just clarify that a little bit. We have designed this such that whether a member needs surgery or not, if they engage with the primary care physician, they get the benefit of that engagement plus all 5. So whether you don't need surgery, if you engage in terms of, say, the flu shot or alternative, you go online, you certify, any member can gain the 5. They don't have to have a chronic condition to get the credit. So it's
But
available.
engagement with the
to all.
physician is key to gaining the credit.
I'm sorry.
Engagement with the physician is key to gaining the
Yes,
credit.
that's the key, engagement with the physician.
Okay. Just second question. I went through the entire presentation. We talk in acronyms. It mentions in one of the tables about PCP. What is PCP?
Primary care physician.
Okay,
Apologies.
that's reaching out. I looked through the entire document and could not find the definition, but I appreciate
That's a good
that.
question.
Thank you.
Ms. Mother?
Yeah, thank you. Well, I think this is a really exciting option that you've created, designed here, particularly because, as you noted, in the rural area, in many of the rural areas, we are unable to offer an HMO option. And to me, this closely replicates what an HMO provides, which is really more coordinated care through a primary care physician, and helps to ensure that members are getting both the best care, the appropriate care that they require at the earliest point in time. I mean, that's really what we want, is for people to get early interventions, appropriate interventions, so that whatever they might be suffering from does not escalate and become a really severe chronic condition. Or if they do have a chronic condition, that it's appropriately managed and that they're not taking drugs that have weird interactions or other problems like that. So I think this is an exciting option for our members, and thank you so much for all the time and energy and effort that you put into designing it.
Thank you.
Mr. Miller?
Yeah, thank you for the presentation, very, very helpful. When I look at this from kind of a very simplistic view, I agree with Ms. Mather. I think having something like this new PERS Select, these features are very important for folks who, especially in areas like rural areas where we don't have an HMO and where over the years we've lost, for example, with a lot of state employees lost their rural subsidy for their premiums, so it's been very challenging. On the other hand, there's a lot of people who have chosen PPO options because they do not want to be in the HMO plans. And so from the perspective of customer satisfaction, dissatisfaction, engagement, for those people who have chosen PPO plans for reasons other than just pure cost or availability, I like incentivizing things that relate to health outcomes, as you've done with this new option, and for people who that will be of value. But the drastic increases, the aversive nature, kind of the, we're going to try to drive people to that or punish them if they don't go, really concerns me, particularly with the PERS care, somewhat with the PERS choice. And I think that's something that, for those members who are in those plans, this idea that, oh, that plan is too attractive, we've got to make it unattractive to push people toward that choice, because in such a dramatic fashion, with the increased out-of-pockets, so many of those members would be seeing, especially if they're relatively strained on their income situation already, because those plans are expensive and they've chosen them for good reasons, whether it be for themselves or their spouse or other dependents. So I really want to express my concern about that.
I appreciate that. I think one thing that, when I'm up here as a physician and trying to think about, those interactions with members when you see them, I think that's why we have 3 PPO plans, and the other ones are, so trying to provide choice. And even in the PERS Select, there's choice on if you select a PCP or not. There's choice whether you want to go directly to your specialist. You can still do that without even the change in copayment. So I think the idea is to incentivize them, but there's not anything more that's in this. I don't know.
I'd like to add to that as well. Actually, we're really not trying to, as you put it, drive members to go this way or another way. When you think about it, with the 5 incentives and it coming down to what they're currently paying in terms of their cost share, we may have care members who want to go to this plan because they like the idea of having their care managed, and they're going to be the ones with chronic conditions, and that chronic condition care management would actually be good for them. We don't see a lot of migration in the choice plan, which is our biggest plan. Those members tend to stay there. On the other hand, with that generous 90/10 benefit, you do see some movement from choice to care as well, because they're getting an added benefit with the same level of the deductible. So we're not trying to design something in which we want members to go one way or another. They will make those choices themselves. And I think the not just health and wellness, but the screenings, pre-diabetic screening, which would come through the biometric screening side, alert them to conditions that they would need to engage with their physician. Again, with chronic conditions, if you have a care member deciding that they're ready now, and this looks like an attractive option for them, you actually could see members stay where they are or decide to go to the value-based insurance design product.
Mr. Jones?
Yeah, thank you, Mr. Chair. A couple of questions. First, on the PCP, the 5 areas, if someone already has a primary care physician, then they don't have to do anything. Is that correct?
They would need to go, during enrollment, they would need to select that physician.
If they already have them.
They already have it. So pretend they're in PERS Select now, they would just go in and find them. If for some reason their doctor's not in there, and I can't imagine it because they're in an Anthem program now, right? They're in PERS Select, but there would be an option, and we have that currently, that they could request to have a physician. But it's the same physician network that's currently there. So if you're in PERS Select, but there's no change or narrowing of the network.
Okay. The next question is the estimated cost reduction of this plan is $46 million. Where does that savings go?
Are you asking where does the savings come from? Where does the savings go?
Who benefits?
Oh, the employer and the employee benefit from the savings.
So the employee, meaning active and retirees?
Early retirees, yes.
Early retirees meaning
yes.
What?
Yeah.
Early retirees meaning?
Oh, those 55 to 64 that are not eligible for Medicare but have retired from CalPERS.
Okay. So, and then when Medicare kicks in at 65, then those members are not affected by this plan?
Correct. They're not, Medicare members are not affected by this.
And they're not affected by any of these, I'm looking at this chart, but it talks about deductibles, maximum, they're not affected
No, our
at all.
PPO is a supplement to Medicare. So Medicare designs benefits for the Medicare population.
Okay. Okay.
Mr. LaFaso?
Thank you, Mr. Chair. 2 questions. The first is related to this theme about PPOs in rural areas. A couple clarifying questions. I understand you just say that the new PERS Select product needed to choose a primary care physician that wouldn't be narrowing any networks beyond what they are now?
Right. So
And
you do have to make, just to clarify, if you want to have the $10 copayment, so you don't have to select someone, but if you want the lower PCP copayment, then you would need to go in during enrollment and or after enrollment, but at the time you select a PCP, then you would have a lower copayment. And that does a couple things for us. Like, we can't provide data to a doctor unless we know that you have a relationship with them because of HIPAA. So that's an important piece. When you select a physician, you tell Anthem, I want Dr. Jones to be my doctor, then we can give care gap data to that doctor. We can do things like that, but we couldn't provide that data unless you tell us that's your doctor. So that's what that starts to do.
But that clarification's not about the network, that's about the timing of my decision.
And then in the network, the PERS Select network that you've had since 2008, that's the same network that is in this plan. There's no change from 2008 PERS Select to now.
Got it.
The only change is with the hospital. We're removing the tiering.
Okay.
So you actually have more options on the hospital.
Another sub-question. If I sign up for the 5 incentives, am I still allowed to bypass my PCP and go to a specialist, or is it so HMO-like that I no longer can do that?
You can go directly to a specialist. That's still there. The copayment's the same. What's changing is if you select a PCP, do the active select a PCP, then you get a lesser copayment.
Okay, appreciate that.
That's what's changing. So it's still PPO. You can still go to a specialist, but we're trying to incentivize you to see your PCP. I've worked with a couple employers where they actually they had this concept of like giving some PCP visits away with the, I know I'm seeing a couple of, but the idea would like give 4 PCP visits with no copayment. And what they found was that people went to the ER less because that you have to go pay if you go to the ER, but I could go see my PCP. And this is trying to do that, right? To give a lower copayment so you're more incentivized to go talk to your regular personal doctor before you go to urgent care, the ER, something like that. It incentivizes you to go see your regular doctor.
Appreciate that. So with those clarifications, the question I really wanted to ask is just, do you all have a sense as to what the demand or interest in these rural areas is for this more HMO-like product? Maybe it's unfair for me to suggest that rural members don't want the same HMO options that urban ones do, but just do we know what the desires are out there and how our potential change is going to satisfy them?
Well, we have not, I think through Anthem, our relationship with Anthem and their relationship with our members and the physicians, I think that there is a desire in terms of not just the amount of premium that they pay, but really engagement. We have done some studies, especially in looking several years back at new mothers and how they do or do not engage with an OBGYN physician. And we think that this is going to be something that is going to be very attractive to families out in the rural areas. We think it's going to be attractive to employers who've been asking us to help them with prevention and wellness. And this is a more comprehensive approach than trying to work with individual contracting agencies. I think most importantly, which I am excited about, is I think the physicians in the rural areas are going to be interested in this. And as part of our communication plan, we would want to engage those physicians and let them know that this is an opportunity for them to engage more with their patients and to have their patients actually benefit from that engagement from a plan design perspective. So we are getting interest from physicians, and we believe that this is a product that will work well for families and employers and employees in areas where HMOs don't serve them.
Appreciate that. My cold has scrambled my brain, and I forgot to compliment you on how much this has shaped up since the many sessions you identified in your slide, Dr. Donison. The last question I wanted to ask is, 2 or so years ago, we were talking about wellness programs, and you commented about aligning with Healthier You initiatives. One off-ramp we took about 2 years ago was, what are the responsibilities of employers relative to purchasers on wellness programs? I'm assuming we haven't changed our view on what a purchaser's responsibility is, but with that commented on, can you explain a little bit more how it aligns with carrier responsibilities vis-a-vis employer responsibilities on the wellness program?
Well, I'd like to just touch a little bit on Healthier You and its origins. And the Controller's Office and the Treasurer's Office were two agencies that helped originate Healthier You in collaboration with Kaiser and in collaboration with the SEIU. And the goal was, and it also expanding to Healthy California, these goals align, and that is that that our patients or members take responsibility for engagement in their health and wellness. And so if you look at the 5 things that we've identified as incentive ready, the most important, I think, in that list that applies to everyone is that biometric screening. And you don't have to go to a lab, a Quest Analytics lab. If one is available and you want to go to give the necessary specimen to the lab and it's available, that's a choice. But with these kits, with the biometrics kits, you can actually take, I think it's a blood specimen, and send it off to the Quest Analytics lab, and you get a readout of, your hemoglobin A1C, your you tell them.
Your cholesterol and so I think, it really does, I think, give the opportunity for making wellness accessible to all members, because CalPERS has really done a great job at bringing on worksite wellness, where we have clusters of employees at different places, at the prison sites and at the Cal State. But we still couldn't bring, Anthem and CalPERS together, bring this kind of biometric screening, available to everyone. And so we've worked with Quest to design a plan that would allow us to bring biometric screening. Really, you could participate wherever you live.
Right, and it also includes height and weight, so BMI can be calculated. And so the kit is really about a sort of a comprehensive first-line assessment, which we ask our worksite wellness nurses that go to these sites to do. So in a way, it's more comprehensive, because instead of sending a nurse team to the CSUs, for example, to have a health and wellness day, this can be engaged by the member themselves through this plan design. And we can't get to all rural areas or even urban areas. So the Healthier You started as an initiative to do very similar things, as have other worksite wellness programs. They all sort of align to trying to do this same thing, biometric screening in terms of pre-diabetes or cholesterol, height and weight, BMI for measuring being overweight or obese or normal size. And then part of that is engaging in health and wellness exercise programs. So we think that this actually expands upon the early initiatives that was the desired outcome through Healthier You, and it makes it even more possible to reach more employees and employers.
Appreciate that. My predecessor, Ruth Holton Hudson from the Treasurer's Office, is smiling down. Thank you.
Thank you. Ms. Taylor?
Yes, thank you. Thank you for the presentation. I feel like I have a better understanding, finally, as we've gone through this for the last year, of what's going on. I think I wanted to kind of dig into the co-pays, et cetera. So maximum co-insurance out of pocket is going to be $3,000 all the way across. That's even for PERS Select.
No, let's.
Because that's what it says on your table.
So if you look at slide 7, which puts the 3 out there, the deductible, the individual, you ask about the co-insurance, yes.
Maximum co-insurance.
The maximum co-insurance has existed at that amount forever.
Forever. So I just want to figure out, if you get the deductibles, or not the deductibles, but the incentives to reduce the deductibles, does that lowers that? Is that correct?
The maximum co-insurance?
Yeah.
Is that the question? Does it lower it? That's an amount that if you in your use of health services, that's the maximum that you can go up to that you're going to be held liable for. So they don't really.
So that's not the deductible. That's
No.
That's your.
That's the max.
That's your 80/20.
Yes, you can't exceed that in
Right.
terms of your cost share. It's a cap.
Okay.
It's like deductible plus co-insurance.
Plus co-insurance. Gotcha. Okay, I just wanted to clarify that.
Can you say that again?
Oh,
Court reporter.
yeah. That the maximum co-insurance out of pocket is where the deductible plus any co-insurance, and then it's the max out of pocket. So it's the two together.
So that would include your pharmaceuticals and everything else, right? Your copays for your pharmaceutical. Is it your copays?
Is your co-pays? Since we don't, I'll let Kathy talk about the medical pharmacy accumulator.
Cumulative. Is that what you said?
Right. So it'd be medical pharmacy because our PPO pharmaceutical program is managed by OptumRx. So this is so if you have expensive medical necessity needs in terms of, say, medical pharmacy, cancer, other expensive pharmaceuticals, and you're paying these cost shares, then that's the maximum that you're going to pay.
Okay. So, and then I just want to make sure, so if you've accepted a primary care physician, then anytime you go in to see that physician for your screenings, which your physician should be ordering anyway, your primary care physician, it's a $10 copay.
It is a $10 copay to see the physician. Under the ACA, though, preventive care itself has zero cost share. So if you have an annual physical as a preventive service,
That's zero.
That's zero.
But say it's, maybe it's not your annual, your doctor saw something in your biometric screening and wants you to come in every 3 months for.
That would be a $10 copay.
That's the $10 copay. Do you pay for the lab on this program? Do you pay to go into the lab for that?
If it's a preventive screening, the answer is there's no cost share. If it's follow-up for some type of condition that has been discovered, yes.
Then it's part of the 20%
Yeah.
of your cost share. Okay, so that's what I'm trying to clarify. And then I think I had, I think my other question was the second surgical opinion. So your primary care physician says, I don't know, you need surgery for whatever. The requirement to go to second surgical opinion, even though your primary care said, is that the case? You have to have a second surgical opinion for this?
Yes. And
Okay.
let me, yeah.
And
A surgery could be quite expensive, so
Sure.
it's good to have a second opinion,
as
we encourage.
And Ms. Taylor, I just want to point out, it's for elective surgeries.
Oh, that's elective
Yeah, if you end up in ICU, that you do not need a second opinion.
I would hope not. Okay, so it's the determination of Anthem of what that is, if that's elective. So your doctor says you need to, I don't know, whatever the surgery is that you don't think is elective, your doctor didn't think is elective, but Anthem is saying, no, you need a second opinion on this.
So I just want to clarify, surgeries are coded actually by providers if it's elective or emergency. So if you go into the emergency room and you get admitted, the Anthem doesn't code it. That actually is coded on the
By
claim
the doctors.
by the doctors and the
Okay.
provider, the hospital.
I just want to make
So
sure.
that's how it's coded. If you, so it would be that your doctor, usually a primary care doctor wouldn't be doing surgery, and they would send you it seems like you know.
No,
you're
they'd send
having-
you to a specialist.
You may need a hip replacement. I don't know. We've been watching your hip arthritis for a long time, and they tell you to go to an orthopedic surgeon. And if you talk to the orthopedic surgeon, they might say, nowadays it's gotten so much more complicated. Should you do it? What kind of procedure should you have? The idea is that you would have a second opinion at that point about is it the right time?
Got it.
What kind of procedure, like resurfacing versus total replacement, or there's multiple decision trees and what kind and when and things like that.
So, and that one might result
That
in a
would be a
second
second
opinion
opinion.
because of, even though you need that surgery, because you're not walking in very well anymore or whatever, it's the type of surgery.
it's maybe the type of procedure. So you're still going to get a hip replacement, but it would be the type of surgery within that. There's different thoughts about whether it's, the type of arthritis. I mean, I am a board-certified pediatrician. I'm not an orthopedic surgeon.
Right.
But it's the kind of procedure. Some now providers are doing hip replacements as outpatient if you're low risk. So you could potentially might want to talk to them about what kind of risk you think you have from the procedure and what's the right place for you to have the procedure. Those kind of discussion points. So I think that's important for people to really, how much. Honestly, like what to expect from the procedure and what kind of help you're going to need at home, or all those kinds of things you could get from talking to a second person.
Okay, and are you responsible for that cost? Or is that part of you know what I mean? Is that part of the 20%?
That would be another specialist visit, so you would make another copayment.
So it's another copay, so it's not like 20%. Okay, hold on.
Right, you have another copayment.
So it's 35.
35.
As long as it's.
But then you would get in some ways you're getting paid back for it because you're getting the deductible reduction, the credit.
Oh, I got you. Okay. Flu shot, non-smoking, condition care, disease management. So once you are diagnosed with the disease, then you're saying, obviously, keep coming to the primary care physician, making sure that your disease is managed, take your medication on time, et cetera. How does that get credited? How do you, as a patient, say, okay, I did that? I did all of this.
So the way I was thinking about it, I can remember, but that we have both the providers, if they're providing condition management, as well as Anthem, where you have a disease management program called Condition Care. They're outreaching to the members, calling them, saying, we want to talk to you about your condition. And so if you've been identified for the program and I reach out to you and you say, I don't want to participate, then that would be that you didn't. So we would know, we tried to reach you and you told us no.
Okay. But so say.
If we don't try to reach you, then you get the credit.
Okay. So it's not something that is automatically done through your physician once you've gone in and.
Right, it could be, and that's, I think we want to make sure the maximum people get credit. But if you're pretend you have high blood pressure, and that's actually the one thing, and biometric screening also includes blood pressure. Pretend I'm identified as having high blood pressure. I go to my doctor, and he says, your blood, we're start this medication, and we're going to keep working with you. Your blood pressure looks good. You might not be identified for a condition care program because you're low risk and you're managed. So someone might not be reaching out to you. In that instance, you would get a credit.
Okay.
Pretend you go and your blood pressure is not managed, and now you have to take another medication, and different things are happening. Maybe you go to the ER for a headache, and they think it's from your blood pressure. So now you're starting to get higher risk. A nurse is going to call you and say, hey, can we help you? Can look and see if you're taking your medicine, those kinds of things. That if you say, I don't want to talk about it.
Well, yeah. Then you're not participating.
Then you would not be participating.
Okay.
Wow.
I'm sure that happens, but yeah.
You would not believe it, but it does happen.
Okay.
It's really hard. And I want to Kathy's point about the healthy moms and babies. We've had this Future Moms program. It's a great program, but we don't have enough people participating, even with people calling and trying to participate. And I know that CalPERS has been a great leader in working with the different provider hospitals about reducing C-section rates. But really the next frontier, besides maternity, mom death or mortality, which we're all focused on too, is really reducing preterm delivery. And I think, the March of Dimes has been doing a lot for working on preterm delivery. And why I'm bringing that up is we really need to engage moms in their pregnancy so we know if they have risk factors and we can work with them. Do they have a history of preterm delivery? Do they have, twins or other multiples? Do they have blood pressure that's not being controlled? Are they smoking, and we want to work with them to stop smoking? Those kinds of things that are all associated with preterm delivery, that's really, we want to make sure everyone's educated so they know to be, why it's good to have a vaginal delivery and normal delivery and all those, be educated about breastfeeding and all those kinds of things. But we also want to start making an impact on preterm deliveries and reduce NICU stays, both for the mom,
So I'm
the
a little
baby.
shocked here. Are you saying that you're having trouble getting people to participate in that?
Right, yes.
Wow, it's been a long time since I've had kids, but wow.
Yeah, no, we're having a hard time getting people to participate. People call and they're like, they don't want to be bothered. So that's really what this has to do. If people participate, then they will have their coinsurance waived.
Okay.
So it's giving
But we
an
will have
incentive.
some refusal, is what you're ultimately saying. Okay.
Right.
Wow.
Yeah.
Okay.
So-
I do appreciate this, and thank you for clarifying. I would hope that we have much more participation. As somebody whose lifetime had an HMO, it's foreign to me not to have all of this. So I'm glad to see this, but I hope to see good participation as well. And I'm hoping that the cost isn't counterintuitive to that. But let's hope that driving some of that cost down with their deductibles will help. Thank you very much.
Mr. Slayton.
Thank you, Mr. Chair. I really like this alternative. I think it takes us obviously in the right direction. I'm also happy to see that the maximum out-of-pocket has not changed. For those who have severe chronic conditions, it's very important to have that maximum out-of-pocket. You mentioned about in pharmacy in relationship to this plan being part of the maximum out-of-pocket, but you seem to differentiate certain types of drugs or treatment. So I want to clarify what's in and what's out in terms of being under the maximum out-of-pocket per year.
So this is related to the medical benefits rather than the outpatient pharmacy where you have retail mail and specialty drugs. That hasn't another out-of-pocket that's not related to this. But this is related to the sum of your deductibles and your copays that then go up to that maximum. And that would include medical pharmacy. For example, if you go to an oncologist and have...
So an infusion center, that kind of
infusion center.
treatment. So for example, if I'm taking Advair for asthma as a chronic condition, that's in the pharmacy side, not in this side. And what are the maximum out-of-pockets for that? You can get back to me if you don't have the answer on the top of your head. But
we can certainly, if you give us a minute, perhaps between this presentation and pharmacy,
maybe I'll just reserve the question to when we get to pharmacy.
Yeah.
One other question for you, and obviously what this is trying to do is to get people to have their relationship with a primary care physician, with a doc, but yet still reserve the PPO criteria that you can go directly to a specialist without the referral. So my question is, if that's what we want to accomplish, why do we even have a $10 copay? Why wouldn't we eliminate that? And have a zero copay?
Have a zero copay?
Well,
Yeah, just curious.
Yeah, go ahead, Laura.
I think that's a great question. I think you don't want to have unlimited visits at zero copayment because you may have people using the
Overusing.
primary care doctor for other kinds of relationship advice or other kinds of things. When people have done that, that's
Would I have a
what they
dating
found.
problem, so I need to go see my primary care physician?
Well, or
Yeah, I see
problems
what
with
you-
their kids or
Right.
different things like that. And so at least someone has to think about it, like, I'm going to pay $10. I have to park, and I have to make an appointment, and I have to have $10. It puts some value for going there.
Yeah, it seems like the time and the parking are maybe a bigger issue than the $10 copay, so.
But you have to think about it. I think
Yeah.
that's what the idea was, but to make a bigger difference between the primary care doctor and the specialist, and a bigger difference between the primary care doctor and urgent care, and ER, that we do know that if you have a bigger differential, that people will be more thoughtful consumers.
So the specialist visit is 35. If you go to the ER, what happens?
That has a 20% coinsurance for an ER visit.
So it's just pure 20%. So
Correct.
that gets expensive pretty fast. Right.
Yeah.
Okay. All right. Thank you.
All right, before I go to the next speaker, we have 3 more board requests and 2 from the audience. We're at our 2-hour mark, so I'm going to take a 10-minute break for the court reporter, and we will reconvene at 10:40.